Good morning, everyone, and welcome to University of Louisville Grand Rounds. I am very proud this morning to say that this is Kim Williams, the chair of the Department of Medicine. I am the 24th chair, and today we're going to hear a lecture which is in honor of our 20th chair, Dr. Richard Redinger. Uh, and we have some wonderful faculty who met him and knew him. I came just a little bit after he was gone. And one of those wonderful faculty members is Dr. Christine Kruger, my vice chair for clinical operations, and she is one of our division chiefs in gastroenterology. And she's going to give the proper introduction to the Arlene and Richard Redinger lecture series. And she's going to introduce Dr. Flomenhoft, who is from University of Kentucky, I believe. And we're looking forward to it. Thank you so much.
Thank you, Dr. Williams. Yes, today is a special day. The Dr. Arlene and Richard Redinger lecture series sponsor is a very good friend of many of ours. In fact, under his 20 years as the chairman of the Department of Medicine, he grew the faculty from 43 to 146. And for GI, as you know, Dr. Redinger was a GI doctor. He trained in Canada, and his area of research was bile acids. He continued to work and publish, and even after he stepped down, and even after he retired, he would come and sit in the front row on the left and watch our grand rounds. So he was a consummate educator and teacher. He brought half of the University of Kentucky over here to start the Digestive Disease Center in the early 2000s. And so we've known Dr. Redinger a long time. He actually was the first academic chief of GI here in 1981. So after being chief here in GI, then he became the chair. So he would be very, very happy that we are hosting Dr. Flomenhoft, who I'm going to introduce next. The reason Dr. Redinger would be happy is they have similarities. Both of them trained in New England. Dr. Flomenhoft, who's a professor of medicine, AOA, went to Harvard Medical School, and she everything on her CV is with distinction. So she's an extremely intelligent woman and very focused, like Dr. Redinger was, on advancing science. She, again, had MD with highest distinction, then came to UK, to Kentucky, and had grown up in Cincinnati, so she's sort of from the area. And she stayed at UK, initially thought she wanted to do family medicine, and then she did med peds, and then she was the chief pediatric resident, again with distinction. And then she became a fellow in GI in the early 2000s. Shortly after, they didn't let her go. They said, "You're going to stay here with us." So she became an assistant professor there at the University of Kentucky in 2006. And from there, she continued on to her current day, where she has done numerous things, a lot of clinical research, dozens of papers, probably even more than that of book chapters. So she's an educator, as was Dr. Redinger. She completed continuing her education, healthcare executive leadership, and also LEAD program, very similar to our Arlene program. She's been the medical director of nutrition services. So GI doctors like to eat. We also like to teach nutrition. She's been the medical director of almost all of the endoscopy centers around University of Kentucky. And currently, she is the acting chief of the Digestive Diseases and Nutrition at UK. If you ask her what she's most proud of, she would say that she founded and created the multidisciplinary inflammatory bowel disease program. And she's so about the patient that when she recognized things like access problems with getting in, if you have an acute IBD flare, she created an urgent emergent IBD clinic. She also created, and again, she's med peds trained, she created a transition clinic for little kids that have inflammatory bowel disease and they become teenagers. And you know, when you become a teenager, you stop taking your medicines and you start being a teenager. And there's sometimes a gap when then they get transitioned to adult medicine. So she has this program for 15 to 23-year-old children, because they're still children even when they're 23. So with that, and that I've totally embarrassed her to death, she's gonna share some of her knowledge about inflammatory bowel disease and how it can help primary care doctors manage these people. Thank you, Debbie.
I was using that as my cover slide. Thank you. And thank you for reminding me that at heart, what I really am is a clinician and a physician, and we all start as primary care physicians in our training. And I thought that I would take this opportunity, thank you for inviting me, to not delve into something that I am a particularist in, that might be not that interesting for every internist who attends grand rounds, but to take this opportunity to look at how the particular disease that I treat day in and day out in the population that I committed my career to, how the nature of their disease should affect how we as internists who are all attending this grand rounds might manage these patients when we see them in the office, and what the nature of their disease means for their health as a whole. So thank you. This has given me an opportunity to think about my physician roots. So the learning objectives are to identify the metabolic systemic health implications of inflammatory bowel disease. Because while I may focus on the more classic extraintestinal manifestations and also focus on making sure my patient is in at least endoscopic and preferably histologic remission, the disease has implications beyond just the gut and the things that we usually think about, like skin and eyes and liver. Also, to assess the comorbid conditions associated with IBD that are beyond the metabolic comorbid conditions and adopt treatment strategies. I think Dr. Dryden can tell you that we have a lot of received wisdom from the past 30 years that we're learning over the past 5 years is less canonical than we thought it was. And also understand and apply the recommended health screenings for patients with inflammatory bowel disease. So this is just a brief slide to let remind us of what the scope of the problem is. And this is data from the CDC from 2024. So I feel confident about it. The US prevalence, which is different in different papers, is about 3 million. So we're going to be seeing these patients in our clinics. And this is based on filling data. IBD patients in this cohort are more likely to be former smokers. So they're patients who have some health risk markers. They sleep less than 7 hours a day. Now, is that because they're up pooping in the middle of the night? Possibly. Is it because they have abdominal pain? So I would not say that this is very clearly causal. They fall short of recommended exercise, and this is in multiple papers. However, I also think that if you have IBD with a significant symptom load, you are probably not excited to be meeting recommendations for exercise. You're just trying to make it back and forth in your life and not getting to the bathroom too often. In 2018, the direct healthcare costs of IBD were $8.5 billion, mostly for the medications that have given our patients the ability to do the things that we hope every one of our patients can do. Have gainful employment if that's what they want, go to school, make decisions about whether they're having children, live full and healthy lives. But it is an expensive disease, and it has implications for other health systems in the patient. Primary care providers' comfort with IBD. This is interesting. My partner, Elizabeth Selby, 12 years ago, did a paper that pretty much said primary care doctors wanted nothing to do with patients with IBD, and management of their immunizations, healthcare screenings was felt to be mostly on the gastroenterologist. That has changed over the past 12 years. So a recent 2023 online survey of 1,500 primary care providers, which was inclusive of APPs, physicians, family medicine, internal medicine, OBGYNs. Physicians and primary care providers, 72% of them reported that they were comfortable managing the primary care needs of their IBD patients, including immunizations, cancer screenings, and osteoporosis screening. That is great news. The less good news is that most of these providers the overwhelming majority of them followed U.S. Preventative Services Task Force recommendations, which are not aligned with ACG and AGA recommendations for care of patients with inflammatory bowel disease. So I have a picture here of Moses. Everybody know Michelangelo's Moses. So great art. Moses has horns. Some may think it's an anti-Semitic trope, but what it is a gap in understanding, which is where we are now. The effort was noble. The understanding that Michelangelo had, based on the translations of the Hebrew that he had, was that keranim meant horns, not knowing that it also meant rays of light. So I am hopeful that we will bridge this gap between wanting to do the right thing for our patients and doing what we believe is the right thing for our patients and moving towards doing the things that our patients with IBD need in the primary care space. So remind ourselves what the physiologic milieu of IBD is, and this is an incomplete but brief overview that will at least get us some sense of why these other health problems may come up. So our IBD patients have an increase in pro-inflammatory markers, including TNF-alpha, IL-17, IL-6, IL-23, and IL-12. Each of these has been implicated both in psychiatric disease and in cardiac disease, including atherosclerotic cardiovascular disease and heart failure. There's intestinal barrier dysfunction, which is greater with disease activity, but probably is baseline native to patients with IBD based on familial studies. So baseline patients with inflammatory bowel disease almost certainly have some intestinal barrier dysfunction, which allows for things like translocation of bacterial products, LPS, my favorite from med school, which may have systemic side effects. Also, our patients have dysbiosis. So they have a decrease in firmicutes generally, an increase in proteobacteria. They have a decrease in the number of bacteria who are converting our high fiber diet, which all of our patients eat, not to short chain fatty acids. And short chain fatty acids, as we all know, feed colonocytes, maintain a healthy mucosal barrier and intestinal barrier, but also have important roles in the systemic circulation in terms of cardiac remodeling, liver health. So decrease in short chain fatty acids has important implications for our patients' health. They also have an increase in LPS and other pro-inflammatory toxic bacterial metabolites. And as an unintentional shout out to Dr. Redinger, they have altered bile acid metabolism, which over the past 4 years seems to have secondary and tertiary bile acids have a role in terms of mucosal immunity and endocrine signaling and paracrine signaling for both bowel health and for systemic health. So these are important things to think about. I'm going to do this via cases because that is how I scaffold best, thinking about how these ideas apply to real patients. So our first case is a 43-year-old man who has moderate ulcerative colitis pancolic disease, which has been well managed on infliximab for the past 10 years. We got new and different drugs, but if he's in remission and doing well, we aren't moving. He has noted decreased exercise tolerance over the past few months and an increase in fatigue. And we'll talk about fatigue more in IBD. He reports symptoms of epigastric pain and intermittent loose stool, which do not interfere with sleep, which we may think is increase in disease activity and maybe some GERD. Never mistake heart disease for GERD. People do not die of their reflux. Sorry, Dr. Rogers, quickly, but they do die of their heart disease quickly. He has 3 bowel movements per day. He has blood in his stool less than once a week. He has a family history that is pretty unexciting. No family history of diabetes, no family history of early heart disease. He's a non-smoker. He has a high BMI, 41.6, but pretty average in my clinic. His heart rate is 88. Blood pressure he's hypertensive. His weight is up 10 pounds from his visit 6 months ago. You do a physical exam and he's noted to have JVD, not quite to the angle of the jaw. He has an S1, S2 without any murmur, a non-displaced PMI, but his BMI is 41.6, so you're not so sure about your exam. His lungs are clear to auscultation, and he has bilateral 1+ pitting edema. He has an elevated hemoglobin A1C. He had a colonoscopy within the past 12 months, which was a Mayo 0. And his calprotectin at that time was also where his gastroenterologist wanted it, well below 150 at 65, which is an H on your report, but still is an excellent calprotectin. However, immediately prior to this visit, he saw his gastroenterologist, did a calprotectin because everybody turns their poop in, and his calprotectin was 673, reminding us that just because somebody had a normal colonoscopy within the past 12 months and they've been well managed for a long time, that doesn't mean that they stay well managed. So meet your patient where they are every single time. But we are not here to talk that much about his IBD. We're here to talk about what this IBD means for the rest of his health when he goes to see his primary care provider. So, MASLD, metabolic disease-associated steatotic liver disease, previously fatty liver disease, affects about 35% of the US population and probably more overall. Our IBD patients are not exempt from this and probably have a higher risk of it based on all the data that we have. This is not just because they are obese. However, the idea that IBD patients are thin and malnourished is a thing of the past and should be discarded. 15 to 40% of patients with IBD are obese. So not an insignificant number of our patients are obese. An additional 40% are overweight. So even with regular risk factors, lots of our patients are at risk for MASLD, and we should be thinking of it. Lean IBD patients appear to be at higher risk for MASLD than lean healthy patients. And here's a paper out of Spain by Gomelin's group, which was a cross-sectional case control study that I thought was better than the UK Biobank study to look at, because they really identified patients within this single study identified as obese, lean, or underweight, and they had lots of data about these patients. So they excluded patients with alcohol use. They excluded patients who had had any corticosteroid use within the previous 2 years from evaluation, and any patient who had any other liver disease was excluded. All of these patients underwent ultrasound and elastography, and they were included as having MASLD if there was evidence of steatosis on ultrasound, and if they had a CAP greater than 248, and they counted significant fibrosis as a KPA greater than 8. So a relatively decent study with patients who had IBD without things that might be muddying the water, like corticosteroid exposure and alcohol. And what they found is that there was not a significant difference between healthy controls and the IBD patients and the overweight obese. They both had pretty significant, as you might expect, prevalence of MASLD. However, among the lean and underweight patients, there was a significant increase in MASLD, and we know that portends a worse prognosis for our patients. So we do care about this. Now, they also looked at fibrosis, and while there was not a significant difference based on the statistics, I think we can all look at these bars and see that it looks like there might be a trend towards significant fibrosis among IBD patients who are in the blue compared to the healthy controls. And so identifying MASLD in our patients and treating it appropriately and counseling our patients appropriately about diet, about exercise, thinking about GLP-1s, which I'll get to, and other treatments for MASLD that are coming out every day or every month, without naming any names. But thinking about treatment is important for our IBD patients, and we should not withhold treatment. This was an interesting UK Biobank. I did not get to see the whole paper, but this looks like just having underlying MASLD may increase the risk of IBD in patients over 12 years. This just reminds us that IBD is not the foundational disease. It's happening in a patient who may have other things going on. And so looking at our patients with metabolic disease and being careful to make sure that we're paying attention to what other things may be going on in them is important. This is a quick slide. Everybody thought that maybe there was going to be a close correlation between type 1 diabetes and IBD. Based on the fact that we have lots of shared genetic markers. There really isn't. Maybe if you live in Northern Europe, and maybe if you live in Israel, it looks like there might be an association, but it's not as close as we thought it was going to be. That is not to say ignore it, but that's to say. And then type 2 diabetes and IBD, there's no association well identified, and there's very little published information that I have seen. So this is a place for us to do further research. And just going back to Michelangelo, this is his drawing. He was actually an architect of Julius II's tomb, which is how he actually got to Rome and ended up painting the Sistine Chapel, which was a side project, and he never got this done. So maybe we should buckle down and get this done. Now looking at atherosclerotic cardiovascular disease, heart failure, and IBD. There's been a growing body of literature over the past 8 years around the association of IBD and cardiovascular diseases, and our patients are at increased risk for early cardiovascular disease and early heart failure, or more likely to have heart failure. And our current models may be inaccurate for assessing the risk in the IBD patient that you're seeing in the office. So, of course, all information comes from the font that is Olmsted County. And so this is from a 2018 paper with Ed Loftus, 736 IBD patients, all farmers in Olmsted County, 1,472 controls. There were 339 Crohn's disease patients, 397 UC patients. Overall, the IBD population had fewer risk, not factories, but factors for cardiovascular disease, but they had a significantly higher risk of MI than it was a hazard ratio. So it was throughout the study, they had a significantly higher risk of MI. And they also had a higher risk of heart failure, which tended to be greater as patients aged. Systemic corticosteroid use, probably not surprising to any of us, markedly increased the risk. So for MI, the adjusted hazard ratio was a little more than 5, and for heart failure, 2.5. And you will, if you are a primary care physician or a hospitalist, be taking care of patients who still are getting most of their IBD care as intermittent steroid use. It's not how we hope to manage IBD, but it is how lots of patients get their care. So be aware that our patients are at increased risk of heart failure and cardiovascular disease when you're caring for them. And this is the same data. This is a meta-analysis actually from before the Olmsted County fountain of accurate data, looking at ischemic heart disease, risk of ischemic heart disease in IBD patients, and you can see that both for ulcerative colitis, which is the bottom, and for Crohn's disease, the forest plot indicates that our patients are at increased risk of cardiovascular disease. His group has done a lot of work in this area, and so this is a paper that was published in Gastroenterology and Hepatology into 2023. And as it applies to our patient, this is the risk of acute arterial events in IBD. As it applies to our patient, you can see there's an increased risk of ischemic heart disease. There's a compositely, there's a markedly increased risk, increase that the hazard ratio favors ischemic heart disease. It favors all outcomes, but ischemic heart disease is the one that is most obvious. But as applies to our patient, disease severity is a risk factor for acute arterial events. And our patient has increase in symptoms. He also has an elevated calprotectin. He has some epigastric pain, which should probably if you're the gastroenterologist seeing him, you should probably not give him, which is what I would tend to do, a little alginate and send him on his way. He needs to see his primary care doctor. He needs to be evaluated for heart disease. The same group looked at predictors of cardiovascular disease using the UK Biobank, and this was published this year. Cardiovascular risk factors, except for dyslipidemia, were more prevalent in the IBD group. But major adverse cardiovascular events incidence was significantly higher in the IBD group on a 12 and a half year follow-up. And you can see that that's a pretty significant p-value right there. 846 events versus 691 events per 100,000. So they applied the prediction models SCORE2 and PCE to both groups, and they found that the prediction models underperformed in IBD groups. So the prediction models that we're using in primary care to help risk stratify our patients may not be appropriate for our patients with IBD, or may need to be taken with more concern. This was more marked in patients who did not have elevated high sensitivity CRPs. And this is just to show which of the risk factors were more prevalent. So low physical activity, which I think we can all agree, having diarrhea or joint pain doesn't make you want to exercise. They were more likely to have hypertension, more likely to have diabetes, and more likely to be a current or former smoker. In this group, they were less likely to be overweight and less likely to have dyslipidemia, but again, it's the UK Biobank. And this is the area under the curve. You can see is the performance is less in patients with inflammatory bowel disease than it is for non-IBD patients. So what does this mean? Well, it means that we have to be sensitive to the fact that when we're seeing a patient in the primary care setting with inflammatory bowel disease, that symptoms that should concern us or might concern us for cardiovascular disease should have an added layer of concern. What can we do what can I do as a gastroenterologist? Well, at this moment, I can optimize management, try to get my patient into endoscopic remission, try to get them into histologic remission, practice good medicine with treat to target for our patients to keep the inflammatory milieu as minimized as possible. But it's possible that in the future, we'll have some other therapies that might modify more systemically and not just at the mucosal. Possible, I don't know. What we also should be doing is making sure that we're screening and managing traditional risk factors very aggressively. Start patients on statins when it's appropriate, at the time it's appropriate. Don't wait. Make sure we're managing their hypertension. I was telling Dr. Kruger that I end up managing hypertension sometimes in my office because people are afraid to manage hypertension. Then I ask for a lot of help. And then optimize implementation of the screening. And recent screening guidelines for ASCVD suggest that patients with rheumatoid arthritis and lupus are a special situation, which should have further consideration for risk factors. I would put forth that patients with IBD fall into that category too, that we should not assume that having applied a screening tool, we have captured the full spectrum of their possible disease. And I want you to remember that we talked about increased an increased inflammasome, and this is probably what drives the increased risk. But this data is emerging in the basic science and translational science area. Now, our patients are not just at risk for ischemic events; they're also at risk for for heart failure, and we saw that in the Olmsted study. And this was held up in several studies, including the Swedish population-based study that was also published last year, showing that, again, at a pretty significant follow-up, patients with IBD had an increased risk of heart failure. And this, again, harkens back to pharmacological consequences of our drugs, which I'm about to talk about in a minute, endothelial dysfunction and thrombotic risks. Please never fail to start your patient who is hospitalized with inflammatory bowel disease on pharmacologic prophylaxis for DVTs. Our patients get clots. So it is received wisdom that anti-TNFs worsen heart failure. and cause heart failure in the right patient. It is received wisdom, let me say, whispered into our ears on Sinai, because it turns out not to actually probably bear up in reality. So this is a retrospective pharmacovigilance study from 2017 to 2022. There were a fair number, 9,817, almost 10,000 cardiovascular adverse events were reported to the FDA. This study is inclusive of major adverse cardiovascular events and heart failure. And the only anti-TNF that had an association was adalimumab, which is over here. The rest are all to the left of zero. And there actually is some rheumatology data that suggests that anti-TNFs may be cardioprotective in patients with ankylosing spondylitis. So this patient is on an anti-TNF. We're concerned he has heart failure. He also has active disease. I have lots of other drugs. I am probably inclined to change this patient, possibly because received wisdom is still heavy in my heart, but also because I think an IL-23 might be better for this patient. So primary care providers, pick up the phone and talk to the gastroenterologist and help us make a plan together, because certainly I'm sure Tad has had this too. I've had patients with heart failure and anti-TNF who we don't have a good reason for them to have heart failure, and we've been able to change therapies and help manage their heart failure better. And then we have another class of drugs which has been received to give you a clot when you take a pill. And those are our JAK inhibitors, which we will all recall from the oral study, which was the rheumatology, the RA study. It looked like there was an increased risk of cardiovascular events. And I think there was also some market increase of cardiovascular events in people who had risk factors on JAK inhibitors. And that was mostly on tofacitinib. And looking at a post hoc analysis of Octave, which was our tofacitinib registry trial, there were 8 patients who had major adverse cardiovascular events. And a post hoc analysis showed that age was the greatest risk factor. And recent data, post-marketing data, mostly in the rheumatologic data literature for UPA, which is our most used JAK inhibitor, suggests that there's not an increased risk. Now, I would caution that post-marketing data and those analyses look at patients on UPA against patients on adalimumab, and that's the one anti-TNF that may have some cardiac risk factors. So this guy has all the things that would make a GLP-1 a useful medication for him. And yet my primary care colleagues often feel hesitant for good reasons. And my patients also feel hesitant to start GLP-1 agonists because they've heard that it's going to make their stomachs hurt. It's going to give them diarrhea. It's probably not safe for them. They're going to get ileus. And the question is, are GLP-1s safe in IBD? And the answer is yes. And in fact, we have a study ongoing looking at IL-23s and GLP-1s in obese patients. So I just wanted to review this literature pretty quickly about GLP-1 based therapies in the course of inflammatory bowel disease. This is the Danish registry trial. They looked at their endpoints were IBD hospitalization, starting an anti-TNF, which is pretty much like getting a diagnosis of IBD. You'll be on some biologic therapy in the United States, probably. Need for steroids or surgery. They looked at patients between 2007 and 2019, so a wide range of GLP-1 agonists for these patients. There were 3,750 IBD patients who had type 2 diabetes. These were the only patients who were on these medications. And there is no effect, no change in patients on GLP-1s versus not.
Were their BMIs high?
I do not recall that BMI was I do not recall their BMIs, but we do have data on GLP-1 use for patients with high BMI. And there are even some centers that are using GLP-1s for pouchitis, for the constipation. So, not us, but Sinai. There's a recent FDA warning for ileus in GLP-1s, and in the Danish registry, again, there was no correlation with GLP-1 use and ileus. So this is safe for your patients. If we don't believe the Danish registry, my friends over at NYU Langone with Jordan Axelrad also published this year that there was no increased rate of IBD exacerbation for patients with IBD. And they looked at their experience, which was 224 patients. 43% of them had UC. These patients are obese, mean BMI of 33. And I just imagine at NYU Langone that that's pretty obese. Mean duration of IBD was pretty long. These were pretty sick patients. 43% had been on advanced therapy. 67% of them had been hospitalized. So that's a fairly sick patient. That's moderate to severe IBD. Significant number of them had had surgery. They matched them to IBD patients not on GLP-1s, and they compared disease activity the year within the group 2, disease activity the year prior to the prescription to the year after for all of their endpoints, and there was no difference. Nothing's significant either between the groups or within the patient with their own controls. And then lastly, out of Tel Aviv and Iris Doughton's group, this suggested that obese patients may actually experience benefit from GLP-1s and have a decrease in hospitalization. So all of this to say for our patient, get him on a drug, consider heart failure, consider ischemic heart. Do not just treat him with reflux, alginate, and change his IBD medication, all of which are reasonable things, but he probably has more systemic things going on that we should be cognizant of as internists. How are we for time?
8:36.
Okay. Case 2. We're leaving heart disease now, where I feel vaguely uncomfortable. Case number 2 is a 40-year-old woman with ileocolonic Crohn's disease who was diagnosed at age 16, so she's had her disease a long time, and she's on the oldie but goodie of azathioprine, which nobody ever changed because it worked for her, 150 milligrams daily, and infliximab, 7.5 mg per kg every 6 weeks, so a reasonably high dose. She had an ileocolonic resection at age 25, so she has some reasons that she may have some symptoms beyond her IBD. And she continues to have symptoms of generalized abdominal pain, intermittent loose stools, which do not interfere with sleep, but she sleeps very poorly. She has bilateral knee pain, which really bothers her. She has severe fatigue, and she naps most days as soon as she gets home from work, gets up briefly, and then goes back to bed where she has poor sleep all night. And now we had Michelangelo, so now I'm giving you Kehinde. Her white blood cell count is 5.3. Her hemoglobin is 12.6. Platelets are 250, so we're not too worried about inflammation. She's got a lovely albumin. She's got a nice MCV. All those things that as internists you look at closely are not giving you any clues. She has a ferritin that's a little low. We'd like our patients' ferritins to be about 100 for IBD so that they have decent iron stores for when things go south. She has a B12 that looks like maybe she could be taking her parenteral B12 a little better. Or maybe she's got some bacterial overgrowth. She has a calprotectin that is where we would like it, but calprotectin's not that sensitive for small bowel disease. So your gastroenterologist colleague is not that 100% sure about how she's doing. And because of the fatigue, her azathioprine is stopped because azathioprine causes severe fatigue. Calprotectin is within goal, but since your GI colleague knows that calprotectin is not that sensitive, she gets a scope and she's a Rutgers I0, which is as perfect as you can get with no evidence of disease activity. But she still has knee pain, but you're thinking it's not related to her IBD when you're seeing her in your office, and she still has fatigue, and she still doesn't feel that good. So what's going on with her? So first, to get the knee pain out of the way, if you would like to give your patient in your office who has passing musculoskeletal pain NSAIDs, tradition is you do not. Tradition may be wrong. So this is a VA study. I was taught never give an IBD patient NSAIDs. That is probably not not a fair thing to be doing for our patients. If your patient has a lot of cardiovascular risks, probably not, but not because of the IBD. So a VA study between 2004 and 2016 looked at 15,705 veterans who had NSAID exposure in IBD and 19,326 who did not have NSAID exposure and also had IBD. They did 3 analyses of these patients. They did a Cox proportional cohort analysis, which told us exactly what we already knew from received wisdom, that the hazard ratio was 1.24 and that maybe we should not be giving our patients NSAIDs. However, they also did a propensity analysis matching patients based on prior disease flares, and that risk washed out. Then they also did self-controlled case series looking at these patients in the year prior to NSAID use, during the time of NSAID use, and 6 months after NSAID use, and they found that there was no correlation between flares and NSAID use. So I am not saying go hog wild with NSAIDs, but I am saying that we should treat our patients as we would like to be treated in some ways. And if a patient would benefit from short-term NSAID use, like this woman, consider it. Do have the discussion that it is still true that some patients may flare, but we don't know who they are, and that every patient's experience is their own, and they should call, or you should have a way to be in contact with them if their IBD changes after you make that recommendation. Also, this person is not sleeping. And a thing that I didn't do until recently is consider sleep very much as its own issue in patients with inflammatory bowel disease, but it is evident that treating sleep disorders helps with pain, helps with IBS, and there's a little data that it may actually also help with inflammation, and that's coming out of Corey Siegel's group in Dartmouth. It's pretty weak, it's small, but maybe, and it's an easy and safe therapy to recommend to your patient. So more than 50% of patients with IBD meet criteria for insomnia, both in terms of sleep latency and ability to maintain sleep throughout the night. More than 70% of patients want their providers to ask them about sleep, and most of those people would welcome recommendations. And the recommendation should be cognitive behavioral therapy first. It's been shown to be effective in several small trials. It reduces sleep latency, it increases sleep duration, it decreases fatigue. Patients have decreased pain symptoms when they have improved sleep. And as I just said earlier, it may, the jury's out, decrease inflammatory markers. And why might that happen? Well, again, our chronic inflammatory milieu that goes back and forth. Stress is a pro-inflammatory condition, which may contribute to disease activity. Disease activity may contribute to stress, psychological disturbances, and sleep disorders. It alters CNS function, it disturbs the hypothalamic pituitary axis, and there also is an autonomic nervous system input. And increasingly, are you doing a lot of breathing and vagal stimulation stuff for patients with?
Rogers is.
I mean,
Yeah.
we've studied this in patients with vagal nerve stimulators for gastroparesis, and if you had them on the stimulator, there's actually a reduction in inflammatory bowel disease symptoms over those who are the control. So, I mean, there is, and of course, there's the ear stimulation studies that have been done in France, and then some other external vagal nerve stimulators. So I think that decreasing the abnormal signaling that's going on in these patients is
useful. And there actually is a trial ongoing for vagal nerve stimulation and rheumatoid arthritis that you can find on the trial website.
Yeah.
So this person has symptoms, doesn't have IBD. She can be managed in her primary care office. And her gastroenterologist, who may be somebody who's, well, we know what she's on, so she's not just giving her steroids, but nonetheless, this should be considered because it can be hard to get into your gastroenterologist. So does this patient have ongoing active inflammation? No. Could this patient have bile-associated diarrhea? Yes. You could treat that with a little cholestyramine, bile acid binding agent of your desire. Could this patient have small intestinal bacterial overgrowth? Oh, certainly, because she's had an ileocecal resection. And does this patient have celiac disease? These should go through your heads. However, it is very likely that this patient may have IBS, and this data has been shown over and over again, but IBS is much more common in patients with inflammatory bowel disease than it is even in the general population. And it's pretty common in the general population. So treat IBS if you think there's IBS. You can treat IBS and IBD together. You are not diminishing either one of those diagnoses by choosing to help a patient have better quality of life by treating their irritable bowel syndrome. Healthcare utilization among patients with IBD who have concomitant IBS is much increased, even over patients who have active disease that is occult. So they are more likely to get endoscopic evaluations than even patients who have active IBD that is not occult. They are more likely to have radiologic investigations than other patients, except for patients with obvious active IBD. They have spend more time in the office. They're more likely to get steroids by a little bit, so it's worth treating IBS. And as discussed earlier, IBS is a disorder of brain-gut interaction. And I think we all know this. Our patients with IBD have had at some point in their past an inflamed bowel. They have had at some point in their past probably LPS and other toxigenic markers in their system. And so they are primed to be sensitive to pain, particularly from the GI tract. We should also discuss, because this is part of the guidelines for management of IBD, psychiatric comorbidity beyond IBS and insomnia, which insomnia sometimes feels like a psychiatric comorbidity. Individuals with inflammatory bowel disease have elevated rates of psychiatric disorders, which I think we all know compared to the general population. 30 to 60% of these patients have anxiety or depression. They want to be asked. They want to be asked by their primary care provider. They want to be asked by their gastroenterologist. They want somebody to see this. It is not their disease. It's not that you get their IBD well and their psychiatric disease improves. Both things need to be treated. Psychiatric comorbidity is linked to higher healthcare use. You may, at this institution, have some patients who are frequently hospitalized or in the ER because they have concomitant psychiatric disease with their IBD, and it's hard to untangle those in a way that affords your patient dignity and lets your patient feel that they're being heard. So it's an important disease, both for the patient and for the healthcare system. These patients have lower adherence to therapy. They tend to believe that whatever you're offering for their IBD is probably not helping because they still feel pretty crummy. And it may be an independent risk factor for disease activity, as we saw on that earlier slide, that there's an interaction with the central nervous system, which may upregulate inflammation when patients are under this stress. Emerging data that the psychiatric disease may be tied to the inflammatory milieu. Manitoba, so good things come from Olmsted County, good things come from Canada in terms of data. 154 IBD participants, 63% with Crohn's disease. 57% of these patients had more than one psychiatric comorbidity. I think only 5% of them had PTSD. My experience is that probably more of my patients seem like they meet criteria for PTSD. Certainly they get medical PTSD. They had major depressive disorder. Substance use disorder was more common in Crohn's disease patients, anxiety disorders, and over 70% had multiple disorders. So the AGA guidelines and the ACG guidelines for healthcare screening and vaccinations recommend mental health care screening annually. So patients should annually be screened with a recognized tool for depression and anxiety. And the guidance to gastroenterologists is that we should refer patients for appropriate treatment. And what that means is that we send them to their primary care provider, who should use whatever therapies they think are appropriate to manage patients' depression and anxiety. Because a psychiatrist is a hard provider to find sometimes. And so this needs to be managed. And then case number 3 is quick and easy, but I want to make sure that I don't leave you without going over what our actual guidelines, what our most recently published guidelines are for primary care management of patients. This is a 33-year-old woman who has ileocolonic Crohn's disease. She was diagnosed at age 28 with severe disease. She has no children. She's failed adalimumab and she has failed ustekinumab. And because she has a job where she travels frequently, she was started on UPA, and she is currently in endoscopic remission on UPA 30 milligrams daily. She likes taking a pill once a day. She feels well. She comes for her annual visit. She's 33. She's getting married. She's thinking about having children. So this is a little bit to discuss what you do when your patient is well in the primary care setting. So both men and women want to discuss family planning. I can't tell you how long it took me to recognize that men also want to discuss family planning, and primary care providers are good to discuss that. The more information that patients can get and the more reinforcement that we can give people that they are healthy people who can lead healthy lives, the better. Men want to know that the risk to their children is somewhere between 5 and 10%, and I usually a little lower for fathers, but they want to know that they can have healthy children and that their children are not going to have necessarily inflammatory bowel disease. They might, but it's more likely that they won't. They want to know that their medications are safe in pregnancy, and pretty much everything for fathers is safe in pregnancy. We recommend holding methotrexate, but it probably doesn't matter as much as it does for women. Offer women with IBD contraception. I write a lot of contraception because primary care physicians feel uncomfortable writing for contraception. If I can get my patient into some place where they can get long-acting reversible contraception, that's great. If I can get them an Nexplanon or an IUD, all the better. But women with IBD can become pregnant. They can have healthy pregnancies. They can have healthy babies. It is much better for women with IBD, and I would argue for all women, to do so at the time of their choosing, and the time of their choosing should be when they are in remission and have had deep sustained remission for some period of time. I write for SLIND because there is an increased risk of thrombotic events with IBD, so I tend to choose a progesterone only medication. But you don't have to do that. The risk of clot in pregnancy is far higher than the risk of clot with an estrogen-containing oral contraceptive. So meet your patient where they are and have that discussion. Also, know which medications are safe in pregnancy and do not take patients off of medications just because they become pregnant. Generally, all biologics can be continued in pregnancy. It's safe to become pregnant on them. Those are our IL-23 medications, mirikizumab, risankizumab, guselkumab, our IL-12/23, ustekinumab, all of our anti-TNFs, and our anti-adhesion molecule, vedolizumab, are safe in pregnancy, safe in breastfeeding. Our small molecules are not known to be safe in pregnancy. And this woman is on UPA. She's thinking about becoming pregnant. I would not withhold an effective medication from a patient just because of that until we have more discussion. But if she's thinking of becoming pregnant in the next 12 months, I would discuss, and the primary care doctor should send her to have that discussion, change to something like IL-23, which is safe in pregnancy, and make sure that she can remain in remission on an IL-23. And then also always discuss healthy habits. So we have good data that Mediterranean diet may help maintain remission for patients. Patients should be counseled on a Mediterranean diet. We probably should do some work to find out if other culturally appropriate diets help maintain remission, but Mediterranean we know is all the rage. Discuss exercise and discuss sleep habits with them. And then we also want to make sure that we're doing appropriate colon cancer screening. Or appropriate screening, look at that, for cancer. I say cancer, I think colon. It's not all colon cancer, just because I'm a gastroenterologist. We want to do appropriate cancer screenings for our IBD patients. We want to give them vaccines and immunizations at the appropriate time. And so cancer screenings for IBD patients are a little different than they are per U.S. Preventative Services Task Force. So IBD patients are increased risk for skin cancers. We recommend screening IBD patients for skin cancer annually. I usually start around age 30 based on Gestalt. However, if you are comfortable doing a skin exam, that is a skin screening, but do a skin exam. You have not done cancer screening for your IBD patient if they are fully dressed for their entire appointment, or send them to a dermatologist if you're not comfortable doing a skin screening. Also, have a low threshold for lung cancer screening. There is some recent data that suggests that IBD may be associated with an increased prevalence incidence of lung cancer. So do appropriate lung cancer screenings for our IBD patients. And then anal and cervical, there's an increased incidence of anal and cervical cancers in our IBD patients. This goes to vaccination. Make sure that you're offering HPV vaccination to all of your patients. They may have gotten their HPV vaccines in childhood, but you really need to know that information because there was a lot of tension when HPV vaccines first came out with parents about whether or not they were going to give their children vaccines for a STI. So ask and get documentation. I would rather revaccinate somebody than not vaccinate them. Cervical cancer screening for women with IBD is different than it is per U.S. Preventative Services Task Force. We recommend that recommendations are that women who are sexually active have 3 negative annual pap smears before they go to every 3 years. So that is significantly different. Also, in terms of bone health, we recommend that our patients get screened at the time of diagnosis for osteoporosis, certainly earlier than U.S. Preventative Services Task Force if they have had more than 3 months of steroid use, if they're smokers, which we wish they would not be, if they have low BMIs, if they have hypogonadism, which for men, corticosteroid use can lead to that, so we need to be sensitive to that. So DEXA scans are much more liberal in the IBD population than U.S. Preventative Services Task Force. And then in terms of vaccination, varicella vaccine for everybody older than 19. So Shingrix, Prevnar for my patients as soon as they're diagnosed. So as soon as you know your patient has IBD, you should start vaccinating them. The things that put our IBD patients in the hospital and kill them are often vaccine preventable diseases, and we want to prevent that. So it's been a quick hour, but I recently summited my first very small mountain. So here I feel a little bit like I'm summiting my second very small mountain. Maybe it's a little bigger. So thank you very much.
We do have a couple of minutes for questions.
Oh, Dr. Williams, if you still want to, I'm sure you would you want to have a question you would like to ask to start off? Or maybe you know.
Yeah, he would be asking a heart-related question about pathophysiology, probably.
I will say that when I reviewed for this, I think that we have a dietitian affiliated with our clinic who I refer to quite often. I do think a high fiber Mediterranean diet, really trying to push patients to have a healthy diet, may obviate some of these risks or at least reduce them. I do think we have to be careful about that though, because diet is multi-layered, right? What your mother fed you is love. And so when somebody says, you should be having a Mediterranean diet when you grew up on fried chicken livers and chow chow and beans that have been stewed all day, what you're also saying is that your family hurt you. So I think we need to be careful about how we talk about diet, and we need to be inclusive about how we talk about diet, because it's essential to being human. It's essential to staying alive, and changing how people eat really changes something core about them that we should be gentle with.
So I think clinicians are nervous about fiber and high residue diets in IBD folks. Do we need to change the texture or restrict it when they're active?
I think only if they have stricturing disease. And I do sometimes have a hard time telling if my patient is only eating French fries because they have stricturing disease that I'm not catching, or
They like French fries.
They like French fries. Also, there's plenty of soluble fiber that patients can safely eat, right?
I'll step in for Dr. Williams on the heart question because this is a concern, and I have a lot of problems with the orals. I'm sorry, the Rinvoq versus Humira in the rheumatoid arthritis patient study, the oral surveillance. But given the Rinvoq black box warning that we have versus the 5 times higher risk that you pointed out with steroid, how do you balance the potential adverse effects of each one of those medications?
So I don't know what you're doing. I am, and we have a study for this too, but it's having trouble enrolling. I sometimes use JAK inhibitors to induce remission as a bridge to what I think will be a safer therapy in an older patient. But I think that steroids have far more risk. They're NF-kappa B inhibitors, right? And they affect 1% of the transcribed genome. We know that they have lots of risks. We don't have a good way off of them once we get someone on them. So I have an open discussion that there's a risk and that the other therapy I have to offer you has much more risk. And if you feel at all funny, you call and you go to the ER. Is that?
I think so. I think that it's really overrated, the risk of Rinvoq associated problems. Maybe in those higher, older patients with lots of risk factors, I would shy away from it. But for the rest of the patients, I think that the benefits are definitely outweighing the potential risks of the medication, especially when you look at the alternatives such as steroids.
But in the context of this particular grand rounds, if you've got a patient on a JAK inhibitor and they're presenting with any kind of symptoms,
Sure, get it every day. Yep.
Dr. Barty?
Yeah, I would certainly reiterate what you just said, that I feel like low, rather high fiber diet doesn't have to mean a high residue diet. I think those need to be separated. But the other thing is a question that came to my mind that a primary care doctor might have about your second case, the woman who was well controlled on azathioprine and TNF inhibitor, and then the gastroenterologist or somebody stopped the azathioprine, and the colonoscopy was normal. But would the question not come that if you now stop the one medicine, maybe she'll go back into a flare? And how do you watch for that on the primary care side?
So on the primary care side, I think that you need to involve your gastroenterologist. And as a gastroenterologist, as the IBD person, I am still doing treat to target when I pull a medication off. We also have increasing data. She was on a pretty high dose, 7.5 mg per kg every 6 weeks. And so I also would get levels on her to make sure that we're staying at the desired level for anti-TNF, probably about 4 months after I stopped her, 3 to 4 months after I stopped her medication.
So my question was, and you have a multidisciplinary clinic, you mentioned a little bit about genetics and how with diabetes that really didn't pan out to be the cause. But when would you refer someone like her to rheumatology? Because she still had that knee pain. I'm not sure that was her poor sleep. And, would you look for other autoimmune markers in her?
So I would not look for other autoimmune markers, but I do refer to rheumatology early and often. Mm-hmm. Some of that is also because there's emerging data that dual therapy is very effective for many patients and very safe. And the only way you can get dual therapy is you've got 2 of us, but I would refer early. Okay. I also use sulfasalazine, and I think a primary care doctor could do that. Mm-hmm. I just wanted to debunk the NSAID story. Okay. But yes, you can use sulfasalazine also for patients with joint pain quite safely. Just make sure that you're screening for sulfa adverse events about a month out, and also screen renal function about a month after starting.
And put them on folate.
Particularly, yeah.
So I think that was really phenomenal. I think all of us could listen to you for like another hour or 2. Wish we could. I think for the primary care provider pointing out, and I had patients that died of heart disease 20 years ago that had IBD, and I was unaware of the literature in heart disease. So I think pointing that out, that it's a multi-system disease when you've got interruptions in the gut flora and inflammation going other places, It's very, very important, and primary care doctors help us manage these patients. So thank you.
Thank you.
Very much.